Hi everybody, my name is Mitchell Farmer and today we are going to be discussing the posterior abdominal wall and the retroperitoneal structures. This is part 1 of a 2-part video on Laboratory 5. The first thing that we're going to be talking about today is the kidneys. As you can see here, we're looking at a posterior view of the abdominal wall, having removed most of the abdominal viscera. Left kidney, right kidney on the model, that is. Just I guess as a note, here with the kidneys that I have present in this model, we have just the viscera of the kidney as well as the suprarenal or adrenal gland. In the cadaveric dissection, there will be perirenal fat, perirenal fascia, pararenal fat, all present. And so the kidneys won't look quite this clean. You'll have a whole bunch of dissecting to do in order to get the kidneys to look like this. Alright, now what I wanted to talk about to start with is the left kidney, the one that I have a cross-section of. Starting with the left renal vein. So the left renal vein drains into the inferior vena cava, but it also has several tributaries itself. I'm just going to zoom in here. The first of which, superiorly and alongside the medial pole of the kidney, is the left suprarenal vein, which drains the left adrenal gland, highlighted here, as well as the left inferior phrenic vein, which is not shown. Another tributary of the left renal vein is the left gonadal vein. The left gonadal vein travels all the way inferiorly in the abdomen and has several branches that I don't have present here to help drain the gonads. In this case, the ovaries, as this is a female model. The important thing about the left gonadal vein draining into the left renal vein is that if you have a compression of the left renal vein by, for example, a tumor, you can get a varicose engorgement due to back pressures of the pampiniform plexus of the, let's say, the left testy, just from that back pressure moving all the way down, all the way to what would be the left testy. And this can result in a testicular varicocele. And I guess the last point of note regarding the left renal vein is that it's crossed anteriorly by the superior mesenteric artery, as seen here. And so it's crossed anteriorly, just a reminder, anterior, posterior, this is a lateral view. It's crossed anterior by the superior mesenteric artery, while posteriorly there is the descending abdominal aorta. And so between these two is a point of potential constriction of the left renal vein. So as you can see on my dissection, we have the renal pelvis, which I'll go into more detail shortly, but the renal pelvis terminates into, or turns into more so, the left ureter. It is the most inferior structure coming out of the renal pelvis, and it lies retroperitoneal on the posterior abdominal wall, anterior to the psoas muscle, which I've highlighted here, the major and minor, if the minor is present in your model or in your cadaveric dissection. It runs, I'm going to move laterally here again, it runs posterior to the left gonadal artery, and this is what's known as a bridge over troubled water, the water being the left ureteric vein, or sorry, the left ureter, my apologies, with the bridge being the gonadal artery. And one of the important considerations of the ureter as it moves from proximal to distal to eventually empty into the bladder is that there's several points of normal anatomical constriction. There's the uretero-pelvic junction between the existing, I'm just going to zoom in a bit here for you, existing between the renal pelvis, highlighted here, and the ureter. There is a point of anatomical constriction as the ureter passes over the pelvic brim. Recall the pelvic brim is this outlined area here, demarcating the true and false pelvis. So as it crosses over there, there's another point of constriction. And then there's what's known as the ureterovesical junction, which is where the ureter enters the bladder. This is just a posterior view, and here's the highlighted ureter. And those are three major points of normal constriction, or normal anatomical constriction in the ureter. And the reason that these are important is that if you have a kidney stone that exits the renal pelvis and enters the ureter, those are three places that it could very well get trapped. And so those would be some of the first places that, say, a urologist would look if they were trying to find where a kidney stone may be. Finally, the last thing I wanted to discuss in regards to the ureter is its blood supply. It has being so long and traveling through such a distance of the abdomen and pelvis, it has a variable blood supply. First, it's supplied in the proximal abdomen by ureteric branches of the renal artery. You can see those branches kind of coming off here into the renal pelvis. Well, those will continue to descend and help supply the proximal section of the ureter as well. As it moves more distally in the abdomen, it is supplied by multiple things. It's supplied by the gonadal veins, highlighted here, as well as the abdominal aorta. And as we descend and the abdominal aorta bifurcates into the common iliac veins, left and right, it would then be supplied by the common iliac veins. And then finally, as it enters the pelvis, its supply would both be the internal iliac, which I don't have here, but it would be the branch medially of the common iliac, as well as the common iliac, and in the case of females, the ovarian artery, and in the case of males, the inferior vesical artery, both of which I don't have present on this model. Now, if I move back superiorly in my model, we can kind of take a really quick look at the right kidney. So the right kidney is pretty much exactly the same as the left kidney. The only thing that I want to discuss as far as being different is that the right gonadal vein drains into the inferior vena cava as opposed to the right renal vein, whereas on the left side, the left gonadal vein drains into the left renal vein. And so if you have a compression of the right renal vein, you're not going to see, for example, that testicular varicocele present. So moving on from the right kidney back to the model's left side, I would like to talk a bit here about the sectional anatomy of the kidney. So first, just zoom all the way in here. First, there is the renal capsule, which is a tough fibrous outer layer that can be seen right here, just this really thin change in color that extends all the way around the kidney. Moving in from that, there is what is known as the renal cortex, which is the peripheral 1/3, approximately from here to here, of the kidney, which contains most renal corpuscles and portions of the renal tubules. As we move deep, we come to the renal medulla, which is the inner 2/3 of the renal viscera, and this consists of the renal pyramids, highlighted here, as well as the columns, which are the areas that exist between the pyramids, containing the loops of Henle of the nephrons, the functional unit of the kidney. Now, the pyramids empty into the renal papillae, which are these areas here at the base of each pyramid, and allow for draining of the pyramids. From there, these renal papillae right here empty into minor calyxes, which are kind of seen right here, which then empty into the greater calyx, which is basically the majority of the renal pelvis before it empties into the ureter. So that's about everything for kidneys. Let's move on to a quick overview of the adrenal glands. So the adrenal glands can be seen here on the left side and here on the model's right, and they lie retroperitoneally between the diaphragm and the superior medial pole of the kidney. So you can kind of see how it's tilted towards the medial pole of the kidney as well. In the cadaveric dissection, they will likely be surrounded by perirenal fat and enclosed in renal fascia, but here you can see them laid bare. The perirenal fat and renal fascia provides them with an attachment to the diaphragmatic cura, and this is kind of their primary anatomic relationship that you'll notice. So if I add back the diaphragm here, you can see how these muscular, I suppose you could say muscular extensions of the diaphragm, this being the diaphragm, and if I highlight it, you can see it better here in light blue. You can see the close anatomical relation between that and the adrenal gland on both sides of the body. And so those things would be attached in the cadaver via the renal fascia and the perirenal fat. So if we start on the left adrenal gland, in the cadaveric dissection it'll likely be more crescent shaped, and its immediate anatomical relations include the stomach, spleen, pancreas, and left crest of the diaphragm, whereas the right adrenal gland is more triangular in shape and is largely in contact with the liver and inferior vena cava, as well as the right crest of the diaphragm. The blood supply of these guys, there's kind of three primary blood supplies: the superior, middle, and inferior suprarenal arteries. Now, each of these arteries comes from a different place. The superior comes from the inferior phrenic artery, the middle comes from the abdominal aorta, and the inferior comes from the renal artery. Unfortunately, the model only has the inferior suprarenal artery, which can be seen here, coming off of the renal artery, or inferior adrenal artery coming off the renal artery, as previously discussed. So now I'm just going to quickly open up another view for us here, so that we can get a better look at the aorta in the inferior vena cava here. So the aorta and the inferior vena cava lie retroperitoneally, and if I add the diaphragm, you can see that they enter the abdomen, so this being superiorly being the thorax, inferiorly being the abdomen. They enter the abdomen at levels of T12 for the aorta, approximately, and T8 for the level of the inferior vena cava, whereas this final hole right here is approximately the level of T10, and that would be the entrance of the esophagus into the abdomen. I'm just going to hide the diaphragm again. And I guess in the dissector, they review the levels of, or I guess you could say the branches of the aorta and their respective levels. So I'm going to try and do that really quick. It's a bit hard to memorize, so if you don't get it, that's fine. I'm just going to go through it really quickly to be consistent with the dissector. Starting with the unpaired visceral branches. So there is the celiac trunk, as we've already discussed, existing approximately at the level of T12 and L1. And just to show you that the levels I'm talking about are vertebral levels, not spinal levels. So we have the celiac trunk existing approximately at the intervertebral disc of T12 and L1, and this supplies the foregut primarily. Then there's the superior mesenteric artery existing primarily at L1, highlighted here. This supplies the midgut. And then there is the inferior mesenteric artery, which is approximately at the vertebral level L3, and that supplies the hindgut. So those are the unpaired branches of the aorta, and then there's the paired branches of the aorta. There is the renal arteries, which are approximately at L1. There are the gonadal arteries, seen here, which are approximately at L2. Then there is also at L1 is the middle suprarenal arteries, but they're not present in my model. And so those are the paired visceral branches, so going to the viscera. And then there's the paired somatic branches. If we move superiorly, there's the phrenic arteries, which are approximately at T12. The inferior phrenic arteries, to be specific, and these would supply the diaphragm. As you can see, they curve upward in the shape of where the diaphragm would be if it was present in my model. And then if we move inferiorly, there's the four lumbar arteries seen here, highlighted here, coming off the aorta. And they're basically the equivalent to the posterior intercostal arteries in the thorax. And then, once again, if we continue all the way inferior, the bifurcation of the aorta into the common iliac arteries takes place at approximately the level of the umbilicus, which can range anywhere from L3 to L5. So that's the aorta. As you can see, we also have the inferior vena cava. And so I want you to recall that the veins of the gut don't drain into the inferior vena cava. So while the aorta supplies everything in the gut, the veins of the gut don't drain into the inferior vena cava. They actually drain into the portal system, which then drains into the liver, or is one with the liver really, and then the liver drains into the inferior vena cava. This is an important anatomical consideration because one of the reasons that liver metastases are so common is that the whole gut drains to the liver. And so say if you had colon cancer or something like that, and there is a metastasis, one of the likely spots that it would metastasize to is the liver because of that portal system. Now back to the inferior vena cava. It's formed approximately at L5 here, seen here, by, similar to the aorta, the common iliac veins, and it enters the thorax as previously stated at approximately the T8 vertebral level as it passes through the central tendon of the diaphragm. Its main tributaries are the hepatic veins, highlighted here, which drain the liver after it has drained the portal system, as well as, but it also has some lateral visceral tributaries, the right and left renal veins, which I only have the right present here, as well as the right suprarenal vein highlighted here, which would drain the right adrenal gland, whereas the left adrenal gland drains directly into the left renal vein, which I don't have present, so that we could better visualize the aorta. And it also has lateral paired somatic veins as well, including the inferior phrenic veins. Here's one highlighted here, the right one. And if we continue downward, there's also the lumbral veins, which are complicated, but this is kind of a simple show of them. As you can see, they follow the lumbral arteries quite closely. So that's a really quick review of veins and arteries of the vena cava and aorta. If you didn't quite get all of it, that's fine. The last thing I want to talk about in this video is a real quick review of some of the major lymph nodes of the abdomen. Don't worry, this looks more complicated than it actually is. The first thing I want to talk about is the cisterna chyli. So just to orientate you, this is an anterior view, superior, inferior. Here's the descending aorta. Here's the celiac trunk, which if you recall is approximately between T12 and L1 at the intervertebral disc level. And just posterior to about this section of the aorta is something known as the cisterna chyli at approximately L1, L2 vertebral level. And this is where most lymph nodes of the abdomen, pelvis, and lower limbs ultimately drain. And it's kind of an engorgement or a large sac almost. And it drains then to the thoracic duct, which carries up through the thorax, posterior to the abdomen, all the way up to, now this is the cervical vertebrae, all the way up to around approximately T1, where it then drains back into the venous system in order to return that lymphatic filtrate to the venous system. So this might be difficult to see in the cadaveric dissection, but here it is in this, and as you can see, it would drain essentially the whole pelvis, abdomen, and lower limbs before turning into the thoracic duct. And then finally, there's a couple quick lymph nodes that you might have seen when you were dissecting the unpaired branches of the aorta. There are the celiac or periaortic lymph nodes. There are the superior mesenteric lymph nodes, and then finally there are the inferior mesenteric lymph nodes. Pretty simple, just named after the unilateral branch that they come off of. And that's basically everything I want to talk about in regards to lymph nodes. You may also notice I have the sympathetic chain here, and just one single note about sympathetic chain, which is highlighted here in the abdomen, is that if you move up to the thorax, this is approximately where the level of the thorax begins, you can see that the sympathetic chain starts or is more posterior in the thorax, and then you can see how it moves more anteriorly in the abdomen. So if you are searching for the sympathetic chain as you go through the dissector, I recommend looking more anterior than you would have in the thorax last year. Alright, so that's the end of part 1 of this lab. Now you can check out the video part 2.